Hello, everybody, and welcome to another podcast of the Sensory Approach to Manual Therapy. Today, my guest is Pavel Goldstein, who is the head of the Integrative Pain Laboratory, also known as iPain Lab. He is also at the School of Public Health at the University of Haifa, and he's going to be my guest today, talking essentially about touch, pain, chronic pain, acute pain, and where we're moving forward with our ability to properly and easily understand pain and get a better client story of pain so that we have less of a subjective and more of an objective understanding of where we're moving forward with pain. So welcome.
Thanks, Troy. Thanks for having me here. And yeah, I'm very excited.
Yeah, so the first thing that got me interested in contacting you was an article that I'd read in a massage therapy magazine called Can a Loving Touch Reduce Pain? And as a manual therapist, and as most of my followers or listeners, and even a lot of my clients who listen to my podcast, we're all interested in manual therapy and touch therapy because that's our primary mode of treatment. And so an article as wonderful as Can a Loving Touch Reduce Pain? For me, obviously, I gravitated towards it and I loved the read. And I found the story very compelling. And I found the story also not necessarily that bizarre. It was wonderful and it was unique because it was yours and your partner's, but it wasn't necessarily something that clients haven't told me about or that other massage therapists or physios haven't expressed a similar reaction. So I just wanted to get, if you want to tell everybody a little bit about that story, and then what made you inspired to essentially further go down the rabbit hole of the research behind it, beyond just, oh, I had a great experience and then moving on to something else in life.
Yeah, thanks. So at some point of my life, my wife was pregnant. And basically when, the time we got to the 8 months, she started the delivery process. So we go to the hospital and we go to the delivery room. And, I had my BA in psychology. So, I felt like, I have tools really to help my wife, to manage all this pain, right, and the stress. And apparently, BA in psychology is not enough to manage it. Right, so I really tried different tools, and I don't remember, right now I don't remember what it was exactly. But at some point, he said to me, like, "Shut up and just hold my hand."
I was going to say, interesting moment to try to be a psychologist to your partner, which normally doesn't work to start with, let alone throwing in labor.
Yeah, exactly, yeah. So I did it. I holded her hand, and when we talk later, after all this chaotic process, so she said to me that basically holding the hand was very therapeutic for her, and she didn't feel much pain when I was holding her hand. And I was amazed, like, I was, using a lot of touch in generally, so I wasn't like much surprised, but still, like, in this very stressful situation when I didn't have anything like to suggest her, the touch was something that kind of saved me, and maybe in our relationship, I don't know. So, yeah. So I, at the same time, I was in search of my topic for my PhD. So I decided to take this idea and to construct a scientific study based on this concept. So that's what I did. I designed a study, of course, with my supervisor and my collaborators. My supervisor was Professor Simon Shammai-Tsuri from University of Haifa. So we designed a study. We invited romantic couples, and we provided pain stimuli to the women, to the female partners. And the man was in different condition. He could, in one condition, hold her hand or be just present there, or be outside, or in fourth condition, we also had a stranger who was holding the hand. So I think it's also very important because, touch is very, what is important in touch is also a context.
Intimacy and contextualization around the touch.
Yeah, exactly. So we ran this study and we found that romantic touch reduced the pain of our female participants. But I think more interesting was we found a very interesting correlation basically the effect of analgesia was much harder for couples who was more empathetic, with more empathetic partners specifically. So couples where the partner was more empathetic, the effect of touch was stronger.
Yeah.
Okay. So I think,
this is,
this result. Yeah, go ahead.
This is really interesting because as manual therapists, we are taught in school to really remove the romance aspect from touch because it's supposed to be therapy, right? And it's there's a lot of qualities in manual therapy that are unknown. There's a lot of stuff that we still don't fully have answers for about why it works. And this is really what this podcast is about trying to understand a lot of the unknowns. And one of them is often context. You're sitting in a room. For most massage therapists, most clients who get massage therapy, not all of them, but most are fully undressed or in their underwear. They're laying under sheets and they're being touched by another person. And outside of your romantic partner and possibly your doctor, there are very few humans who touch almost your entire body when you're either fully undressed or undressed. And there's often this miscommunication or a lack of understanding with new massage clients who create sometimes an unhealthy connection with their therapists where they feel closer than they really are. Often it leads to them divulging secrets and stories in their life that they wouldn't normally divulge to a massage therapist who's not a psychologist and not trained to do any of that kind of stuff. But there's this sense of intimacy that often is apparent in massage therapy. And it's interesting because you're saying that romantic touch and that empathetic touch seem to have a more positive effect on pain reduction. And yet it's something in massage therapy and physical therapy and all these other versions that we specifically try to remove from our environments. And it just, it leads to a tricky ethical scenario in my mind of, well, if it helps my clients get more pain-free, but also I'm trying to avoid the romance, that's a tricky line to walk now in the future. So that's an interesting point to have to bring up.
Yeah. So I can clarify it. So I'm not sure that this is a completely romantic component because, empathy is very general term. Like, it's your ability to take shoes of someone else, right? So it's basically your ability to understand what happens to the other, right? And that's what we found. Like the people who have this ability, right, to get to better understand what's going on the other side, they success better to help their partners to reduce the pain, right? So if we take it like more generally, we know from previous studies that social touch, can communicate different emotions, stress, right? So in this context, we can think about touch as a communication tool, right? So you can communicate your empathy. You can communicate your empathy with a partner, but you also can communicate your empathy to a client, right? So if you have this like empathetic skill, right? So you not necessarily need this romantic component, right? So specifically in a couple, use romantic component because this is like what connect you, right?
The empathy pre-exists.
Yeah, exactly. But if you're professional, you know how to create this, let's maybe also call it, how we call it, working alliance, right? So psychologists call it working alliance. So you also create here alliance with your client.
Yeah, in massage, we call it empathetic touch.
Exactly. Yeah, but I sorry, but I want to bring this example from psychotherapy because actually, in psychotherapy, there's a term we call it common factors. So a common factor is basically something that have a therapeutic effect, but not directly related to your psychotherapeutic tools, right? So, and what we understand from the studies, there is no like good or bad therapeutic instruments, but what actually is really effective is this alliance. If you know how to create alliance with your client, you are an efficient therapist, psychotherapist.
So that actually ties into my last podcast I just did with a lady named Dr. Luana Poloka. I'm not sure if you're familiar with who she is.
Oh, yeah, of course.
So I just did a podcast with her. I just published it the other day. And one of the things, on placebos. And I just taught a class on placebos at a convention. And one of the things we talked about in that podcast was conditioning and expectation. And I think condition and expectation, particularly the expectation, really lead to that alliance. If my clients come in and they say they're experiencing certain symptoms, certain discomforts, and I'm able to tell them that based on my experience, based on their pathology, based on the return to average, the return to means of their injury, that they should expect these results in this many days, this many weeks, this many months, the recovery period, the prognosis, and it's met, then all of a sudden they feel trust, and that they go, okay, this person is someone who understands my symptoms, they understand my experience, they understand my story, and they also have a good handle of how I'm going to progress. And it creates that sense of trust and alliance. And I think that's often one of those unsaid components behind any version of therapy, be it psychotherapy, be it getting your nails done, getting a pedicure, being it facials, being it getting a massage, manual therapy, even a doctor-client patient relationship, where that level of alliance, that level of trust, the greater the trust, we see with some research, the greater the trust, the greater the outcomes. The less the trust, the worse the outcomes, same treatments, same medications. And so to me, that's always one of those interesting components. And it brings me to a question on the study you did here. You had said you only had female subjects who were the ones having pain subjected. Was there a reason that you chose not to have men on the receiving end of the pain and women being the empathetic touch? Was it just as a control, reduce variables? And is there potentially a future study where we'll have men receiving the pain and getting empathetic touch from a female partner?
Yeah. Thanks for this question. So we tried different settings, research settings in different directions. Originally wanted to run it in both directions, but this was just like so complicated in terms of time. We couldn't really arrange it. So that's why we decided to take one direction. And, I basically just, since I was inspired by this delivery room situation, right? So I just, use it for my research study. And that's how we got specifically to these settings. But definitely it's really interesting also to run a reverse direction and to see how it works in reverse, in opposite direction.
It would be interesting too, I wonder, because as a male therapist, I receive both female and male clients. But a lot of female therapists who I speak with and I visit primarily receive male clients. And a lot of, and to me, that's always an interesting thing, is that male clients traditionally want to see a female therapist. Female clients don't care who they see. And when you talk about that empathetic touch and the pain, it's interesting to see if that empathetic touch is naturally conditioned to be a motherly touch, a female expression of touch, and less that male conditioned, I'm a tough man, blah, blah, blah kind of experience. So that empathetic touch is harder to get from a man. And that's it's just an interesting cultural component, because different cultures view that differently. And I wonder if that would ever play in. I wonder if the research ever could get to a point where we would actually be able to see, females tend to have a more empathetic touch, or at least they've been culturally conditioned to believe so, kind of concept.
Yeah, I think it's very complicated question. Like causality is always, I think, the most complicated part here, right? So we can see some correlations between different processes, but to understand the causality is very, very complicated, right? So I guess we can today really to answer it. We can just kind of
too many variables,
different areas, right? And try to explain it from cultural perspective, from neuroscience perspectives. But so I guess we can also have both, right? So we have some genetic background and some also our environment that also shape our behavior, right? And that's really also very important in our development and in our society. So maybe at some point we understand better all these processes and the composition of these processes. Because I think, what was really new in our research is actually some mechanistic understanding of how this empathetic touch works in neurophysiological mechanisms using. So basically, in our first study, as we said, we just, measured the levels of pain and empathy. But in our second experiment, we did very similar setup. But this time, we also measured electrophysiological signals from the brain of both participants, and also physiological measurements such as heart rate variability and respiration rate. And the goal of this experiment was to understand mechanisms that underline these effects. And what we found that basically when in the condition where comes just pain without a touch, we found decrease in level of synchronization between the brains. So we have some level of synchronization in different social situations, right? And what we found that pain decreases synchronization between the brains of two participants.
So,
right?
If they're not touching.
If they're not touching, exactly. But when comes a touch together with the pain, we see increase. Really, it's like boosting the synchronization. So like touch is really trying to compensate and to increase the synchronization between the brains. And also the same findings we found for heart rate variability and respiration rates.
So when you say synchronization in the brain, like here you just said heart rate and breathing, those are more body related. But in the brain, are we thinking more that stress levels are equalized? Do we see cortisol levels equalized? Do we see wavelengths change? What are the synchronization statistics that you're looking for when we see with touch versus without touch?
Yeah. So, in this study, we didn't have measurements of cortisol, like different hormones. It's really interesting to see how really the process that we found correlate also with hormonal changes. But basically, we found that the synchrony, like the way how we kind of communicate with each other on the brain level. So we kind of try to simulate the processes. Basically, this mechanism may underline this therapeutic effect of touch. So basically, the pain itself is a stressor. It's a huge stressor, and it just basically creates some disconnection between the partners. And when they have touch as a tool, they recreate this communication and even make it stronger. Like, you have different level of stress, and you have also the tool how, to recreate this communication and use this tool. And for more empathetic people, it works better. We replicated this finding. So more empathetic people also have high level of synchronization in touch and pain.
That synchronization that you're describing, was that, and the communication component to it, was that primarily only through touch, or were they also allowed communicating verbally with each other?
No. It's just tactile communication. We didn't use any verbal communication.
That's really interesting. So the pain, that leads me to a whole other podcast that I'll have to find specialists, and maybe you can help me find people who know about this stuff, but just about the idea of touch as a communication tool, because that leads to the idea of, can touch be a communication tool? Which, it's not a leap in logic too hard for us to say yes, but it's a leap in research to say we know it is. But to touch, it's not a, as somebody who primarily touches people all day long, it's not hard for me to sit there and say, well, of course, touch is a communication tool. I can give a loving touch, I can give an aggressive touch. But at the same time, it's a different thing to say, well, touch communicates clearly. And so that's a very interesting beginning step to the idea that communication is the touch behaves as a communication tool.
No, definitely. But if you think just about in terms of development, our development, when we have preterm babies, what's the most effective tool to manage preterm? Skin to skin.
Yeah, touch.
Skin to skin. Basically, like we don't have, today we live in this so complicated technological world, but no one invented a better tool than skin to skin.
So that actually leads me to another question, and this is deviating a little bit from some of the stuff that we talked about, but it's a very good question. Can touch communicate clearly then? Like if I say I'm happy, I'm communicating very clearly an emotion, a sensation, all these things, and contextualization around it. Touch in some examples, like when I touch my daughter, I have a 6-year-old and a 10-year-old. When I give them a caress and a loving touch when I'm putting them to the bed, it's quite clear the touch is calm, loving, and I can do more aggressive touch. But in our general everyday life, you're on the metro, you're on the bus, you go get a cup of coffee, you touch someone's hand accidentally. Are we shutting communication down in that touch, or are we just not perceiving the communication? I don't know if there's space for it in this podcast, but it leads me down a rabbit hole of thought process around the effectiveness of touch as a communication tool. Because in an intentional environment, like a massage clinic, I can see how touch has very clear communication. But in a non-intentional environment, just in our daily lives, it leads me to a whole slew of questions on the effectiveness of touch as a communication tool.
Yeah, but I think we can think about this like touch as intelligence, like sensory intelligence, right? So you have a tool, but you need to learn how to use this tool, right? So I guess maybe many people just not aware like of existing this tool, and they maybe not using it correctly or in the full like 100%, right? But when you get to massage therapy, like when you become a professional, you increase this intelligence, right? So you can use this tool more efficiently.
I like that. I'm going to have to think about that and try to put it together in an article format or something for a magazine, because I really like that. That's a good idea. So then from this, did that bring you down the idea of going down towards chronic pain, or had you already had an interest in chronic pain? And what brought you from the acute more to where you are now, which, by the end of the podcast, my listeners will know why I'm so interested in what you're doing and why I want to promote it, because I think it's really interesting, some of the stuff that you guys are doing.
Yeah. So basically, completing this study, Basically, I was relocated to US, to Boulder, Colorado, and I started my postdoc there. And basically, I found it was 2016. I think it was like a peak of opioid crisis in US, right? So like everyone was talking about it, and it was really crazy. And of course, I was exposed to all these processes related. And I kind of say to myself, hey, it's pretty cool. Like, I'm dealing with social neuroscience. It's pretty cool. And, it's kind of, it's very interesting to communicate it to some media. But, there are so many people around me that suffering from chronic pain and all this opioid crisis. So I felt like bad with myself that, I'm doing all this nice stuff and so much suffering around me. And that's actually how I got to the field of chronic pain. So
and by chance it was in Colorado, where I happened to live there for a long time, and the VA there and the Anschutz Center and Tor Wagner, they happen to be pain. It happens to be by chance a very, very, very specialized area of the US around pain study.
Yeah, I'm so happy that I was like part of this process of establishing this process. So at some point, when I was a postdoc in the lab, we had two therapists who came. So one of them was Dr. Howard Schubiner and Alan Gordon, another therapist. They came and they said, we have a therapeutic approach for chronic pain, but we are therapists, we are biased. So we don't know if it really works, or we just imagine it. So let's run a study and see how basically efficient is our approach. And that's how I started all this story of establishing therapies like PRT and other therapeutic approaches. So Dr. Yoni Ashar, then he was just a PhD student in the lab. He took on himself to run this study. And it was really amazing. It was really amazing study. Just think about it. I was so amazed. They got around $200K dollars to basically fund this study using just crowdfunding. So they just asked money for research. They gave away maybe some meditation or something like that. But it's not the usual model mostly for crowdfunding you need to deliver a product, device or something, right? And people I think it just emphasized how big was the problem of opioid crisis and what's going on with chronic pain treatment. So people was ready to give money right away to establish some new therapeutic approaches.
So with that in mind, with these new therapeutic approaches, and you had already mentioned the PRT, which is something that I wanted to talk to you about. Is that where you were first exposed to? And for those who don't know what PRT is, it's pain reprocessing theory. And I'm going to let Pavel talk about it a little bit more, because I think he has a lot more experience with it than I do. But is that where you were first exposed to it?
Yeah. So that was PRT. There is another approach, EAT, but it mostly was, I think, PRT, right? So
and
I think
do you want to talk a little bit about it?
And communicate what chronic pain is, right? And because it's different from acute pain.
Yeah, so feel free. So this would be a great time if before we get into pain processing theory, reprocessing theory, if you want to talk to us and just highlight some of the differences between what happens with acute pain, where we see actual tissue damage, the threat perception is real, the stimulus level is high, versus chronic pain, which I mean, even now, chronic pain theory, there's still a very big amount of our understanding around chronic. We know a lot about chronic pain, and we know just enough about it to be dangerous, and that we have theories around chronic pain, and they're good. But you actually, I mean, even today, I was reading an article this morning before talking to you about how chronic pain, can it be conditioned? And it's a really interesting question because a lot of people will say, yes, it can be conditioned. And a lot of other people who are just as intelligent will say, no, it can't be conditioned. And I think it depends a lot on our understanding of what condition theory is around pain and things like that. And so our understanding of chronic pain, even though we understand the mechanisms in the brain, the actual reason it exists, the multidimensional components that create pain perception and threat perception and the smoke detector theory and all these concepts around pain is still so hard to say from client A to client B is replicated in the same way. So do you want to talk to us just a little bit about the mechanisms that separate our movement from sub 3-month pain to past 3-month pain?
Definitely. But since you started with conditioning, I want to give you an example. We just recorded a podcast with one of our past patients who recovered from chronic pain. And I want to give this example. So he had migraine that was started exactly at 4 a.m. every day. Pain 10 of 10, like very strong pain. Like people who didn't experience it, you can imagine it. Like how strong is that? So she had super conditioned pain, like it was started every day 4 p.m. Sorry. So we got her to our therapy. Today we have our own therapeutic approach, and we have a system how we help people with chronic pain. So I will skip like this whole process, but today she's completely out of pain, completely like zero. He doesn't have any migraine episodes. He also was on drugs. He got to drugs. He was spending around $2,000 a month for the drugs. So, he was like really addicted. And she stopped completely the drugs, and today she's free of pain. Right? So it's just one of our recovered patients. So I think it's important also to talk about examples. But yeah, about chronic pain. So first of all, I want to argue that pain is really good for us and for our survival. Right? So when we have tissue damage, it's really safe us. There is a rare genetic condition when people don't feel pain. And we know that most of them survive till their 30s. So pain is really important for us. Maybe both of us survived till this podcast because of pain.
I actually teach a class around a concept called the evolution of pain, and how a lot of it's based off of David Brown's studies from the University of Cambridge, and talks about how pain is an essential component to the evolution of the human species, and that without it, we would not be alive today based on infection rates, disease rates, bone densities, muscle strengths, and things like that. And how pain has this really, even though it is an unpleasant experience, it is by far one of the most essential experiences to survival of the species.
Definitely. I wanted to take it later, but maybe I will mention it. We can look at pain as a teacher, right? So because of pain, you can develop yourself. Like, it's really kind of, push you. It's push you really to make some changes, some development. Not everyone success to make it, right? But this is exactly about evolution, right? Evolution. So, we have this diversity. Yeah. So, but, when we talked about pain as really a process that really protect us from a danger, right? So it's kind of an alarm system. You can think about it as an alarm system, and alarm system can stuck. It can stuck. Okay. And, from this perspective, you can think about chronic pain is really like some, damage to this system. This is like one perspective. We can also think it, reframe it a bit differently. So we can frame it, in a more therapeutic way. Like, I have two interpretations. Like one of them is like if I want to shock people, I say like it's, it's a damage of the system. But in more therapeutic processes, I reframe it a bit differently. And I say, so pain is a message, right? That your brain tried to send you. And specifically in the most of the cases of chronic pain, you misinterpreted these messages because you think you have a physical damage, but it can be something different. So you can imagine it as a dog, like, you have a dog sitting in your head, right? And, the dog basically may try to protect you from thieves, right? Or some other, potential damage, right? And then basically have his noise, right? But another, but you can hear your dog also because he's scared, right? He depressed, right? He have I don't know, he want to eat, to drink, and you can think about many reasons, right?
So you actually make me think about something that we just talked about with touch as a communication tool. So pain and touch are processed in the brain so similarly. They get to the brain on very similar pathways. There's the whole pain gate cycle concepts that people are going to be familiar with. And so earlier we talked about how touch is this potentially a communication tool. It was a theory, and I don't want people to think that we're talking fact. We're talking theory. We're in the philosophical nature of touch and pain here. But we thought you'd mentioned that maybe touch is this idea of it's a communication tool that people are just not masters of. And people who go to school on touch become better educated on how to communicate with that tool, touch. So I wonder if pain is perhaps the same thing. Pain is just another version of communication. And when we have the alarm going on, we have, I think Dr. Mosley or Lorimer Mosley talks about it as the smoke detector theory. You talked about it, the dog, the alarm going off. There's all these different descriptive texts around pain being stuck in a positive feedback loop. We can talk about the HPA axis, all these things like that. But are all of them just potentially the pain trying to be a communication tool and us as humans experiencing it going, I'm not smart enough to understand that communication tool because I haven't taken the time to study it. Similar to if we start speaking in Hebrew, I know very little Hebrew. You happen to know a lot. So there's going to be a lack of communication because it's a communication tool I don't understand. And so I think that's kind of the foundation of the pain neuroeducation science, which is the more you understand the science of pain, the less likely you are to continue in your pain loop. So I'm just wondering, based on what you said about touch, because they process in the brain so much, it almost seems like it's a similar component that just because we don't understand it, we see it as a danger and as a threat, but it's just another version of communication.
Definitely. So, but the complication here, it's maybe a really very complicated message that in some cases, it really can communicate some real danger in your body, right? So, for example, you have a pain in your stomach, right? What's the indication of this? So it may be appendicitis, right? Or it may be some other reasons, like maybe you are scared about, tomorrow's lectures that you need to run in front of thousands of people, right? So the same pain can be indicator of completely different processes. I think this is the main complication here, right? And I can say you can say, hey, you're a pain researcher, so just can you classify for me which pain means what? And I can't say explicitly, I can answer you, right? Because it's really complicated and too many factors and depends on many contexts. So we should be very careful when we try to interpret this message. So at some cases, it's really the brain try to say, hey, be careful, there is a danger, immediate danger. And some other cases, it's really try to communicate something different. But, I think here another point where we stuck, right? So, in cases of cancer, we really will try to rely on experts in this field, right? Because we are not familiar with cancer, right? In terms of pain, if we try to talk about pain, is different, right? So from childhood, we get this understanding and knowledge of what pain is, right? We fell down, we get this, scratches, and we have pain. We completely understand the connection, right? We completely understand the biomedical connection of pain, right? Biomedical model of pain. And then later, when we develop chronic pain, we try to use the same model for interpretations, right? And that's where we fail, we fail there. So because we try to interpret completely different processes with kind of simplistic model of biomedical pain.
Yeah, and my listeners and people who've taken it in my classes and stuff like that, they're well aware that we know there's a lot of research out there showing that the level of tissue damage doesn't correlate to the pain symptoms out when we're in chronic pain. In acute pain, that's a different story. That's I fell, I scratched my knee, it's acute. 3 months later, if my knee still hurts, we're moving away from the acute phase. And we know that tissue damage, herniated discs are reabsorbed, and we know broken bones heal, and yet pain persists for an extended period of time. But I want to go back to something you had said earlier that I thought was really interesting, and it made me think of a concept. I imagine you're familiar with the concept of allostasis.
Yeah, of course.
So when you talked about the idea of, let's say I have a pain in my gut and it's appendicitis versus a lecture and I'm causing pain, my theory that I have in my understanding of pain, and my question to you would be, my stress around doing a lecture, which the more clearly I could sit down and logic my way through my fear of lecturing in front of a lot of people, do I know my material, or my slides in the right order, all that kind of stuff. The more I logically sit down and don't let that fear become uncontrollable, I can say, okay, this is anxiety, this is stress, it's helpful, it's going to make me do a better job in my study, versus I have a pain in my appendicitis, I don't know what this is. One is an unknown, one, if I focus on it, becomes a known quantity. But the more people just say, oh, this lecture is super scary, and they don't think about it because they're fearful of it, or this exam is scary, or this job interview is scary, whatever it is. If that anxiety and stress level becomes significantly high enough to surpass their allostasis, their ability to handle stressors prior to essentially going into a fight, flight, freeze state. If that kicks off, would that be enough to instigate a pain response as a defense mechanism to say, change behavior, do something different? In which case, it's not the same as saying anxiety causes pain, but it is enough to say there is a connection somewhere between your ability to handle stressors, allostasis, and your ability to create discomfort in the body.
Yeah, first of all, I think, if you talk about mechanisms, we know that both pain, emotions, and stress can be communicated to our, I forgot the name, to our gut, right?
Yeah, our gut.
We can be communicated to our gut through vagus, right? We have
through the vagus nerve.
Connection. So basically, we know that our gut is always kind of small brain. We found neurons there, right? So, this communication happens in both directions, right? And so all these messages can be communicated. And, when you really prepare yourself to a lecture, so I think it's like a natural process, you have this alarm system in your brain, right? That basically want to keep you safe. He wants really good for you. He wants to keep you safe. But the definition of safe, it's kind of very subjective in this case, right? So how it interpretate, this system really not really care about your well-being, let's say, okay? It really care about your
survival.
Production, it's evolutionary process, right? So it's a really evolutionary system. It's really not care you happy, you unhappy. You need to make your kids, you need to, give your child, you need to help them to grow up, right? And you're done, basically. That's why after 40 years old, basically, if you don't do effort by yourself, basically, you can die.
Yeah.
Right?
So essentially, pain is there to say survive at all costs, propagate at all costs. And that's the limit of what I care about. I don't care if you survive happy or sad, as long as you survive. I don't care if you're a good or a bad parent, as long as you procreate. And so that's really where pain kicks in as this mechanism.
Yeah, definitely. So we need really to understand better. If we understand the language that our brain try to communicate with us, we can really, then we can increase our well-being, can understand, when we understand better all these messages. And I think exactly here, pain comes as a teacher. Because of these processes, all this reprocessing that you should do to be aware of everything that happens here, in your case, your specific case, you really have your personal growth, right? It happens, you have your personal growth really to become more aware to your body, to your communication, brain-gut communication, or some other processes in your body, right? Because we know that chronic pain is not the only way how our brain communicates with us, right? So it can be really reflected through completely different processes, related
Such
to our
as,
stomach, like all the conditions that related to our diets, right? How we eat. So all of this, it's basically different ways how brain try to communicate with us.
yeah, fantastic. So once you got into the mechanisms of chronic pain, you started understanding it more. I want to be conscious of our time constraints here. It's already, we're already 45 minutes in, and I know it might be about an hour to an hour and 30, I'd said, but I want to make sure we get through all the stuff. And I especially want to make sure we get to some of the stuff you're doing at the Eye Pain Laboratory, because I've put up my story. And I think it's really interesting for people to see what you're doing, because I think it's an interesting thing. So do you want to transition into a little bit, talk about what you're doing with the idea of pain detection and the goal behind creating this objective measurement tool, and how you're going about doing it, since it's a voluntary process for people?
Yeah, sure. So my lab called Integrative Pain Laboratory, and basically it's in the fact that pain is really complex signal. We can't just, try to look at the pain from a very specific angle, right? We'll miss a lot. So in our lab, we are trying really to look at the pain from completely different angles. So we research biochemical, neurophysiological processes, but also we use digital tools trying to capture subjective experiences in different ways. So one of our projects called Pain Story. So you can find it on painstory.science.
And I'll have all those links in the podcast so people can go to the website and link it, because I think I love what you're doing. So I'm a big fan of it.
Thanks, Troy. So basically this idea came from, my observation, like, when you come to a doctor, right, and you have pain, the doctor have very specific model, right, of his understanding of pain, and he mostly filter out most of your story, right? All the emotional process that you want to share and what happens to you. And, he need very specific points that he need for his biomedical diagnosis, right? And basically,
so I think the most famous story of that is a client who comes in with a broken leg, and it takes them 20 minutes to get to the point of, I broke my leg and the pain hurts here. And the doctor's sitting there impatiently, and the client's like, well, last week I was moving a guy's couch. Well, it actually wasn't his couch. It's because we had to borrow a truck, and I had to go get a different truck. And all of that story around the truck and the couch is the story that this individual annotates towards their pain. But the doctor's just like, no, you fell, you hurt your leg. That's all I need. When in reality, the story around it actually contributes to their discomfort. And it's like you're saying, the story matters.
Definitely. So basically what we want to do in this project, we want to capture the whole story of the pain. And so we developed this digital platform, web platform, where people can share their stories of pain. So we have some kind of questions that helps them to create this story. So we record the stories and some other subjective measures. And we really want to understand better. We want to develop better also models of understanding the chronic pain, because mostly we as researchers, we read literature, and from this understanding we create we run new research, right? But we don't have much exposure to real patients. And here I think we have this really moment where we can really learn from the main expert of chronic pain, right? People who live with this pain. So we want to have this first-hand expertise of these people. So actually I was one of them. So I can also say us. So we have this project, and we want to use later machine learning algorithms to create some classification to better understand all this complicated experience, because another issue that comes here is diversity, right? So it's a huge diversity of stories, of experiences, of factors that affect pain. For example, right now in this project, what we see really, one of the very interesting factors is actually interpretation of patients, what caused their pain. So just knowing how they interpret what causes that pain, you can predict very interesting outcomes like levels of pain, and also their openness to go to psychotherapy for pain.
There are two studies that makes me think of. One was a study that was done on women going through labor in the Inuit culture in Canada, where they often don't have hospitals accessible. Often it's midwifery delivery. It's not always a doctor, and medication is not always available. And so they were studying pain levels in active labor for women of the Inuit culture versus westernized culture. And they found that in the Inuit culture, going through the process of labor is not necessarily, it's not visualized or viewed as a painful experience. It's viewed as this spiritual experience of growth and development and giving to the community and bringing somebody into the community. And oftentimes they don't describe labor as a painful experience, even if they have episiotomies and shearing and things like that. They don't describe it as painful. They describe it as a joyous, a wonderful moment. And in westernized culture, where we see it on TV, we see it in shows, we see it on, we're culturalized to believe that labor is supposed to be really intense and painful, and the screaming and all that kind of stuff. And that in those experiences, a similar style of labor, even without tearing, is perceived as a painful experience. And there's a lot of components to that. So it's not as simple as saying that it's just their vision of it, because there's less medication in the north and things like that because of resources. But that was one thing. And the other, I'm blanking on the other one. That's too bad. Oh no, the other one was, I believe her name is Dr. Schlemmer or Sherman. I can't remember, from the University of the Palo Alto Center in Nevada. And she talked about how they did a study over a year with 40 subjects, and based specifically on their attitude towards pain and their outlook, they were able to predict with an 85% accuracy whether or not somebody would develop chronic pain. And I found that incredibly amazing, that simply their attitude and their views on pain were enough to actually predict whether or not they would have pain.
Definitely. So, I want to remind you, you started to talk about expectations. You remember it? And I want to talk, to take it in very close terminology. So we call it predictive coding.
Yeah.
So, right. So our brain, is definitely manage every process in our body. But one of the important processes, and also evolutionary important processes that it manages, is actually predicting the future, right? And it's about safety. It's about our safety. We want to know if there is a danger coming soon, right? So we're always trying to predict what's going on, right? And what will come next, right? And basically here, based on this process, we build our expectations. So, and here comes different expectation, culturally based, right? And socially. So, we build this society, we have definitely many good, right? That come in with our current values, but we also kind of created this sensitivity, maybe we'll call it, right? Sensitivity to pain, and, this idea that we need to avoid pain, right? And trying also to develop some technological tools to avoid pain, right? So it's definitely, it's complicated. It's really complicated.
And the predictive thing is an interesting, because when we look at it long term with predictability around pain, we can look at an axon and simply look at, how neurotransmitters fire across the synaptic cleft. When we predict behavior, we can actually start replicating that synaptic activation just by predicting behavior without the actual behavior being replicated, which is an interesting component. And then you translate that to discomfort. And I use an example of an individual who I know in my life who had who had frozen shoulder, but we went to a festival, and now they were pain-free majority of the day, but we went to a festival and they were worried about other humans hitting them by accident. So they put a sling on, and then every time a human got close, they would hyper react. They were over vigilant, and they would get scared and they would tense up. And they kept replicating pain because they were predicting something that never occurred. And in the process of predicting it, they created a muscle contraction or spasm that was high enough in threshold to replicate discomfort. And to me, it was always interesting, that predictability around pain. But we don't see it as clearly in the opposite. If I predict something that is pain-free, we don't see pain-free experiences as clearly. And I guess my question is that because of our mastery of the communication tool that we talked about with pain? Or is it because that's not how the brain behaves? With prediction, it creates threat for survivability. But if we predict something that is a feel-good response that has nothing to do with survivability, the brain kind of says, I don't care about that. So it doesn't actually affect our painful experience in a positive manner.
Yeah. As I said, this evolutionary parts of the brain, they not care about your well-being. And basically, it's the second one, right? So basically, this is not so evolutionarily important, like to predict pain-free moments and safety, right? This is what you do with maybe your prefrontal cortex, and you really try to control through prefrontal cortex all these automatic processes that happens inside your brain, right? And trying really to alert you, right? And so I think this is exactly the dynamic, like how you develop this control over this automatic system that try really to alarm you in the cases where you don't need it.
So then, so I guess my last question before I let you go here would be, based on what we're talking around pain, I'm coming more and I know research is slowly beginning to back this up, but it's still a really tough subject to breach, not only with scientists, but even with doctors, and let alone with clients. And I'm not allowed talking about medicine with clients, so I don't, because I'm a massage therapist. But it's this question around analgesics, Tylenol, ibuprofen, acetaminophen, painkillers, when the pain is non-threatening. So let's say you have a mild headache versus a debilitating migraine. Should we be trying to numb that discomfort, or should we be allowing that discomfort to be a signal in the brain that says, pay attention, change your environment, change your circumstances? Or should it be numb it? And we see this in athletes a lot, right? Like right now, I'm a big hockey fan, and it's the NHL playoffs right now. There's a really high probability, and the Euro Cup's about to go on, and there's going to be a lot of players who are injured, and they get given cortisol, and they get cortisone, and they get given all these medications to play through their pain. And yet the pain is kind of this big signal saying, stop playing. You're potentially damaging your body. So even though the science may say the pain is a good thing for you and you should be paying attention to it, we should be using it from an evolutionary standpoint. When it comes to living with the discomfort, is it simply, I prioritize play over my pain, therefore I want to play and I don't care? Or should we be reevaluating our priorities based around our understanding of pain?
Yeah. So, as you know, like everything in our life, you need a balance, right? So most of the processes that we are really researching and generally exist in our life, they have U-shape, right? They have U-shape because you have like, a point where you're like optimizing point, right? So like you want to increase something, increase. You have optimizing point, and then you have decrease or maybe asymptote.
Diminishing
right?
returns, things like that.
Yeah. So I think it's exactly the same here. Like, I also want to connect it as pain as a teacher, right? So definitely at some point we want to use pain as a teacher, and, we want to develop our pain threshold, but we need to listen to our body. So, specifically when we talk about professional sport, I guess in most of the cases, you kind of, you extend this, and you're not really in a good place. So, when you really use some analgesic really to play, I'm not sure this is a good way to listen to your body, right? If you have really like pain, like small pain, like 3, 4, it's manageable and tolerable. So you definitely can use it as a teacher. Okay, yeah, I understand, right? So, your body tried to communicate me something, but, I'm okay right now. 3, 4, it's not so high, right? So I can maybe a bit continue, and I will see what happens to me, right? But when you use analgesic, you basically, you reduce this communication with your body, right? That's exactly like, example, like in the delivery process, when women, they get epidural, right? So what happens, like, right, on one hand, you don't feel pain, but you also lose control with the birth process. And we know that in many cases, it ends up with a surgery, right? Because you lose this control. So I think it's the same here. We want to, at some extreme cases, when you have a really, strong pain, let's say 7 and above, you definitely, you should use an analgesic, right? Because, you don't want to suffer. That's okay, right? To use it locally for acute pain. But definitely this is not a treatment for chronic pain, and not to use it chronically, like consistently. permanently, right? So this is, I think, where we fail in general our understanding. I think in general, a lack of understanding, we try to treat chronic conditions as acute conditions because, many doctors, they think that the patient wants to reduce his pain here and now. But there is a study that was just published. When you ask patients, they much more worry about your future pain and what will happen than your pain right now. If the patient will know that his pain will end 3 months from now, it will be a completely different case.
Yeah, there was another study that was done around the effectiveness of, or the pain modulation intensity that was necessary to perceive positive outcomes. And essentially, a client was asked, based on our treatment today, if you walk away with 50% pain, or what would your ideal, pain-free experience be before you walk away saying, I paid money and I was okay with the service. And most begin the conversation by saying, I want to be 50% pain-free. And so the clinician says, well, so if you walk out and you're only 40% pain-free, was today a failure? And most clients say, no, that would be amazing, but I would like more. And eventually they all come down to this number of saying, if I only had a 10% change in my pain today, I would still see the treatment as a success. And it goes all the way down to just 10%, which on on the VAST scale, 1 to 10, I went from a 10 to a 9. I went from a 7 to a 6. That's not a lot. And honestly, most good therapists do get better results than that. But it's amazing to see that that's how minimal of a result it takes for a client to say it was a positive experience and that they want to keep going down that process of recovery. That's fantastic.
Definitely. In also a related point, if you talk about pills, there is two studies from Australia. One of them showed that opioids, they're actually effective just as placebo, right? In managing chronic pain, that was one study. And then they, I was very surprised to see that they also run a study with acute pain. And they showed that opioids is effective as placebo also for acute pain.
The placebo stuff, I just, like I was telling you earlier, I just did a podcast with Luana Koloka, and I did 2 others, and I'm going down a bit of a rabbit hole with the placebo stuff. I think it has its limitations, but I think we also haven't delved into enough of its capabilities. And it's a tough subject because it's one of those things in research, reducing placebos is a positive. But in the clinic, I don't care if a placebo is present or not. You got better. That was the most important detail. But I also think some people get too excited about placebos, thinking that it can be the end all be all. And there's an ethical dilemma there, but that's another conversation. Well, I really want to thank you for today. Is there anything you'd like to say to wrap up, or to at least how for people to put their stories on I'm going to have the links to your website if people are interested in putting up their personalized chronic stories. And I want to comment as well for people who are interested in putting up their stories with some of the Integrative Pain Laboratory studies stories, that there's a lot of resources out there showing that belonging to a community on its own who self-identify with a similar discomfort can actually reduce your symptoms of discomfort. So for people who are living in chronic pain, just belonging to a community of other individuals who live with chronic pain, no treatment, no other intervention can actually help reduce symptoms of discomfort because they feel like they have a safety net to fall back onto. So if people are suffering from chronic pain, putting their stories into this iPain Lab story platform could be a really interesting way to help clients and patients with their discomfort as well.
Definitely. Social communication and connection is super important to feel that you're not alone. But, I want to comment on this if you have 1 minute.
I have all the time you want. I want to respect your time. I don't have clients for under 6 hours.
Yeah. So, I see many communities, in Facebook, chronic pain communities. And actually, I become sometimes scary because if it's communities that are not managed by professionals, sometimes it gets to really bad points. Like when people, catastrophize stuff and they just support each other in this catastrophization. And it just comes to not a really good point in terms of, therapeutic effects. So, I think, you definitely need community. But you need this manageable community when you have people who know, who can lead you, right? With some
it becomes like an echo chamber almost, where people
Yeah.
They just focus on how bad life is with no potential outcome that's a positive change.
Yeah, exactly. Yeah.
Yeah, that's a really good point. And on my website, I actually have a lot of resources like, Pain, the IASP. I have some stuff from Pain Canada, Pain BC, all these communities, and they're all managed, which is really great. But that's a component that I'd never thought about either, because in my mind it was always just, oh, the community matters. But it's true that if they just get stuck in the fear avoidance or the pain catastrophizing, it's very easy to just further go down that same pathway. And because all it does is creates that predictability of more discomfort and not necessarily of safety or recovery. That's great. Well, thank you so much. Is there anything you want to tell the listeners before we go?
So yeah, be sensitive and careful with your pain. Listen to it. Really try to understand what message is. So as we said, in some cases it will really try to communicate with you immediate danger to your body. But in other cases, especially if it's chronic pain that you already know, it may communicate something different. And basically, I think the way to deal with it is to understand these messages, and it may be really a journey. It may be a journey. It may be not like something that you can really figure out in one day. But I think it's a really interesting journey and in this journey, you can really grow up and you can develop yourself, and not just in terms of pain, like really to heal from pain, but you can get out a different person and get different skills that will help you in even other aspects of your life.
Fantastic. Thank you so much, Pavel. I appreciate your time. I appreciate your knowledge. And I hope that this podcast brings some people to submit their stories, and that I'm excited to see some of the work that comes out of your guys' laboratory. I think it's fantastic. So thank you so much.
Thanks, Troy. Thanks. I really enjoyed it.